Okay, I'm going to go ahead and just introduce Dr. VanderWeele, and then we'll have a couple more people join. Dr. VanderWeele is one of our medical oncologists here at Northwestern. He's an expert both in GU malignancies and also an expert trialist, particularly with early phase disease and with precision medicine and molecular matching. We gave him sort of a Herculean task to present everything that had gone on and highlights from the recent ASCO meeting, and we're looking forward to it. Pleasure as always, David. Thanks for doing this. You can get off to a slow start, and I think I'm seeing the numbers tick up quite rapidly to 19 attending. It'll be at 50 soon, but maybe get off to a slow start. Thank you.
All right. Thanks a lot, Ashley. It is, it's a big task trying to cover the things that were presented at ASCO, so I decided not to do that and really just kind of focus on some key trials that I think could be influencing practice right away. And because I've sort of pared it down, also happy to sort of stop and have some discussion around things too, if people want to, so you can feel free to jump in at any time. I just ended up leaving bladder out. I am covering two studies, two trials that were in the plenary session. So it's Keynote 564 for kidney and the VISION study for prostate. And then going on to talk about a couple large phase 3 studies for metastatic hormone sensitive prostate towards the end. So Keynote 564, study of adjuvant pembrolizumab. This is for clear cell renal cell carcinoma. So this is for patients with intermediate high risk or metastatic disease. If you had T2 disease, it had to be Furman grade 4 or sarcomatoid, or you could be T3 or T4 or N1. They also included a relatively small number of folks with metastatic disease that then was resected and had no evidence of disease. Those folks had to have had the resection of metastatic disease within a year of undergoing nephrectomy. So patients were then randomized to pembro or placebo. So the pembro was given with standard 3-week dosing, that's 200 milligrams every 3 weeks for a full year, with a primary endpoint of disease-free survival per investigator. And secondary endpoint is overall survival. And so this is the initial presentation of this data. So again, baseline characteristics, about 1,000 patients in the study. Most of the patients had intermediate high-risk disease, so that's T2, sarcomatoid, or T3, but also patients with T4 or N1, and even small numbers of patients with M1, no evidence of disease following resection. So here's the disease-free survival. You can see that the curves separate early at the first imaging on study at about 3 months or so, and then it stays separated. At 12 months, they're separated by about 9 percentage points. That continues at 24 months. So the overall hazard ratio of 0.68, which is highly statistically significant. I think it's an interesting shape to the curve that it separates early and then kind of maintains that distance throughout the rest of the study of the treatment. Maybe separates a little bit further during treatment, and then maintains that following in follow-up. They also presented initial overall survival data. And this is after just 51 overall survival events have occurred, which is 26% of what's planned for final analysis. So both those curves are up close to the top. You do see some separation, and there's a p-value of 0.016. That's not didn't reach the threshold for the interim analysis. So this is immature data. but already, especially beyond the 2-year time point, seeing some separation between those curves with an impressive hazard ratio so far. So if we're subjecting folks to adjuvant therapy, one of the things we want to know is about safety data, and that's some of what hurt the TKIs. A lot of patients were coming off therapy. In general, basically no new surprises in the safety data here. Things that led to treatment discontinuation, 17% in the pembro arm, less than 1% in placebo. And these are the immune-related side effects. I was actually kind of surprised that the side effects on the therapy side and the placebo side looked so similar, aside from hypothyroidism and hyperthyroidism. So really quite manageable. And in the red box on the bottom right, you can see that 7% of patients had high-dose steroids for treatment of immune-mediated AEs. So relatively low number, relatively well tolerated. So pembro with disease-free survival benefit post-nephrectomy and post-metastasectomy, which I think is a place where particularly people are looking for other options, other therapies we can do to try to prevent things coming back. Although also I think importantly, it was not just this high-risk group that was driving the level of benefit, since that was a relatively small proportion of patients. Safety profile is good, and the interim overall survival is encouraging. I think there are questions raised by this. Do we need a full year of pembro? As I commented on, most of the separation is seen at the first 3 staging scans. We also know that these checkpoint inhibitors stick around for a long time in the body, so would a shorter course be equally beneficial? Trying to reduce toxicity, perhaps, certainly toxicity in terms of time. Alternatively, are there ways that we can improve on this? So we currently have the Checkmate study open, which is placebo-controlled study from BMS, looking at IPI plus Nivo, or Nivo alone, or placebo in the adjuvant setting. And of course, most of our advances for renal cell are driven by what we're doing with clear cell. And then we apply that to the non-clear cell heterogeneous cohort, either with or without data. So what about non-clear cell? What can we do for those folks? There's beginning to be more data on some efficacy with the checkpoint inhibitors, although still not a lot of strong data or consensus about what to do with non-clear cell in the first line setting even, but cabo has probably emerged as much of a standard as we have, but I think we're still have a little ways to go before we have adjuvant therapy options there. So moving on to the other plenary session, the VISION study. So PSMA, of course, is protein expressed on the surface of prostate cancer cells, very highly expressed very widely, especially early on at the time of diagnosis, or basically at the time of diagnosis. In late stage disease, maybe a little bit of decrease in expression. PSMA 617 is a peptide that binds to PSMA and then is taken into the cell through endocytosis. And so here we're looking at therapy with lutetium-177 PSMA, binds PSMA it's taken into the cell, gives off these beta particles, which then can lead to DNA damage within the cell and within neighboring cells. PSMA is highly expressed on most prostate cancer cells. It is also expressed in the renal vasculature and in parotid glands, which has been a concern for PSMA-directed therapy. Of course, PSMA-based imaging was recently approved by the FDA, several months ago for gallium-68 PSMA scans, approved for UCLA and UCSF for those two centers specifically, and then more recently, just in the last few weeks, for F18-based DCF-PYL imaging tracer, which is not available yet. I think we're going to have a discussion in this meeting or at this time slot a little further down the road within the next few weeks, but most likely expected to be available for us and others in the Midwest sometime in July. So VISION study, though, is a radioligand therapy with lutetium-177 on PSMA-617. So the study is open to patients with a pretty advanced prostate cancer. They have to have had at least one androgen receptor pathway inhibitor and either one or two taxane regimens. So not just ineligible or refusing chemotherapy, but had to have had received chemotherapy in the past. The trial is set up as standard of care with or without the experimental therapy. And patients and their providers had to determine beforehand what the standard of care therapy would be. And this excluded chemotherapy, immunotherapy, radium, or any investigational therapy. What does that leave? Well, another AR pathway inhibitor, if there's one that the patient hasn't seen before, glucocorticoids, or best supportive care. Basically, it was left up to the treating physician and patient, but excluded cytotoxic therapies and radium in particular. Patients were randomized 2-to-1 to the experimental arm versus standard of care alone. If they were receiving the experimental therapy, they received an infusion every 6 weeks for 4 cycles, although folks who responded to therapy could also receive additional therapy for another 1 or 2 cycles, up to a total of 6 cycles. As a way to enrich for patients who would be benefiting from therapy or to exclude patients with significant PSMA negative tumors, patients were required to undergo PSMA PET CT scan beforehand in order to be allowed onto the study. And 12.6% of patients did not meet the eligibility criteria. And so they had significant non-PSMA expressing disease and thus were excluded from the study. So here's the radiographic progression-free survival data. Pretty good separation between the curves. Hazard ratio 0.4, with more than doubling in terms of the time to progression from 3.4 months to 8.7 months. So this is quite encouraging. And if you look at responses by RECIST criteria, you can see that quite striking differences between the standard of care alone versus those receiving standard of care plus lutetium-177 agent, with 51% of patients with measurable disease having a PR or a CR. And really only 13% of patients having progressive disease as their best response. This also translated into improvement in median overall survival. Again, good separation between the curves, though not nearly as striking as that for radiographic progression-free survival. Also reasonable hazard ratio of 0.62, which translated into improvement in median overall survival from 11.3 to 15.3 months. This is generally fairly well tolerated, was I think the investigators' impression who participated in this in this study, although there were significant AEs. This included fatigue, 49 versus 29%. This included bone marrow suppression, 47 versus 17%, as well as some GI toxicity, 39 versus 17%. As I discussed before, PSMA is expressed in salivary glands, and so there's also some dry mouth. This was considered to be grade 1 the vast majority of the time. Overall grade 3 to 5 events, much higher in the lutetium PSMA arm, although most of these were bone marrow suppression and generally reversible. Although there were a few grade 5 events, and there were 5 altogether, and they were all in the experimental therapy arm, so 0.9% of patients. My understanding is that these were bone marrow related events. So vision conclusions, lutetium-177 PSMA 617. It's a new radioligand therapy. It induces good tumor responses, confers an overall survival benefit. I think this will be, well, it's assumed to lead to FDA approval. I think it's likely then to be a welcome added tool in our armamentarium. It looks like the vast majority of patients will be eligible, meaning that their tumors express PSMA in the vast majority of patients. And the degree of benefit seen in terms of overall survival is similar to other life-prolonging therapies. And so that's seen here with a comparison of olaparib, radium, Cabazi, Enza, Abi, with a quite similar hazard ratios here, 0.62, quite similar improvements in overall survival with an extra 4 months gain. And so while this is exciting, it's a new class of drugs for us. I think it is also a little bit disappointing that the results weren't even better. And I think there are a number of questions raised. One is about the generalizability of this. So the vast majority of patients were Caucasian patients. Only 9% of patients were Black or Asian. In addition, while I think the general feeling is that this is well tolerated, there was significant toxicity. And so I think we'll continue to hear more about quality of life and toxicity. And I think there will be consideration about the balance of treatment toxicity versus improvement in disease symptoms. As covered before, 29% versus 2% for grade 3 to 5 events, and 5 grade 5 events, all of them in the experimental therapy arm. But on the other side, balancing that with 50% of patients with responses by RECIST versus only 3.1% in the standard of care arm. I think in general, in the balance, patients will be eager to receive this. So this was presented a week and a half ago, and 2 days before then, I already had several patients in clinic asking me in person about when this therapy would become available. So I think there will continue to be lots of enthusiasm for this. The results are good. There is very good separation between the curves for radiographic progression-free survival, but can we improve on these results somehow? So could we use more stringent selection? This study did allow some non-PSMA avid visceral and bone lesions, with lesions that were PSMA negative up to 1 centimeter, or lymph nodes up to 2.5 centimeters. And so patients couldn't have very large PSMA negative lesions, but they could have several smaller lesions, and that would be allowed on the study. So if there were more stringent criteria before giving this therapy, would we actually see better results, more durable results leading to better progression or better overall survival? I think that's still a question to be answered. And I think we probably will hear more about that in terms of looking at subgroups based on the pre-study PSMA PET scans. This study was designed to be looking at patients with late-stage disease. All of them had already received an AR pathway inhibitor and at least 1 taxane regimen. What if we brought this into earlier disease states, especially the metastatic hormone-sensitive setting, where we've seen a lot of bang for our buck by bringing therapies into this earlier disease state? That's a question a lot of people are interested in. And in fact, we are going to be opening the PSMA addition study, which is for metastatic hormone-sensitive prostate cancer. This is a global study which has already opened to enrollment, and I think they enrolled their first patient, I believe it in France, within the last couple of weeks or so. So we are trying to open that soon. As I said, I think there will be a lot of enthusiasm for this. The schema for this study is patients for whom chemotherapy is not appropriate or who chemotherapy is not indicated. So patients who are getting an AR pathway inhibitor in the metastatic hormone sensitive setting, and then will be randomized to receive standard of care alone or with the addition of lutetium-177 PSMA 617. I need to double check it, but I don't believe that in this space prior PSMA PET imaging is required, although I need to double check that. So what about accessibility? Is this drug going to be available to patients in general? This sort of gets back to that point about generalizability. Was a less diverse population, at least by ancestry, than what we see in a lot of clinical trials. Is there something about this therapy that contributed to that? In order to get into the study, you did have to undergo a PSMA PET scan beforehand to make sure that you didn't have extensive PSMA negative disease. We participated in the VISION study. We did not have these scans available, so most of our patients were traveling down to Indianapolis to get that imaging done, and so they had to be able to make that trip and get the imaging done beforehand. There's some question: do we even need to be doing that? I mean, I think you could look at this either way. You know, there's a question if we could improve on these results if we had more stringent cutoff based on a prior PSMA PET scan. Conversely, 87% of patients continued on to the study. Only 13% were excluded based on that PET scan. Do we need to do the PET scan at all? I think that's a question worth discussing. And I'm sure there will be more talk about that. In addition, delivering this radioligand therapy requires coordination between nuclear medicine, radiation oncology, medical oncology. Here, this was given by our nuke med folks, but did require a lot of coordination with medical oncology, especially for patients with late stage disease, getting some other standard of care agent. I think this is the first in terms of for a number of radioligand therapies that are coming down the pike. And so I think most centers are interested in developing these relationships and developing the institutional knowledge and capabilities for giving radioligand therapy based on some small informal polling I've done of friends and colleagues. I think not every institution is up and running with this yet, but are certainly interested in getting to that point so that they can be offering this therapy as well as others as they become available.
You know, David, that was an excellent presentation of VISION. Just a couple quick questions, then you sort of highlighted some of this. One is, you know, beyond lutetium. So I thought that the rates of the neutropenia were a little bit higher than I would have originally thought. And I couldn't tell if it was because this was a more pretreated population, even more pretreated than Alsimca maybe, or because the lutetium as a beta emitter maybe was spreading the radiation a little bit more, and maybe there, you know, I know that there's other compounds out there that are actinium based or whatnot. And I just wondered your thoughts about that piece of it, the radio tracer that's being used.
Yeah, it's a very good question, and I'm not really a great expert on this. I know that with the actinium, folks have seen a lot more sort of dry mouth. But I'm not sure about sort of bone marrow suppression. I wasn't really aware of this from other lutetium-177 data being presented. I agree that this is higher rates of bone marrow toxicity than I was expecting. Also, having some patients on this study higher than I was expecting based on just sort of that anecdotal experience. I think you're getting at something that's probably pretty accurate, that, you know, heavily pretreated, likely extensive bone marrow involvement with disease as well. Probably all those things contributed to increased toxicity. Let me just go back a couple slides here. But so standard of care still saw 17% bone marrow suppression, all grades, 7% of grade 3 to 5. But yeah, significantly higher with the experimental therapy. So I do think that people are interested in radioligand therapy in general, and we'll be looking at a lot of different agents to be adding on. I think it may be difficult to, well, yeah, I guess I'm not sure how the drug development is going to happen if patients that receive other ligands, other radioligands, if they're often going to be pre-treated with lutetium-177, since this is sort of first in the field and has a leg up on everybody else, and if that will be an issue, or I don't know. We'll have to see how the field develops. I think also, this bit about PSMA positive versus PSMA negative, I think it's not entirely clear, what kind of selection criteria we should use. Obviously, if all the tumor expresses PSMA highly, that's very advantageous, but it's not clear to me if that is a requisite. If some of the tumor expresses PSMA, is that sufficient to be sort of initiating some kind of response or be attracting the even if not all the cells express it at very high levels. But I think also a lot of people are interested in looking at other agents beside PSMA to be targeting. I do think that late stage disease, you do tend to see an increase in the PSMA negative disease. There tends to be sort of a decrease in PSMA positive and an increase in FDG positive, just thinking about what we know about this from an imaging standpoint. But in terms of therapeutics, I think PSMA probably makes even more sense earlier on in the disease course, or it's probably expressed at higher levels.
Great, thank you so much.
So moving on to metastatic hormone sensitive. So the SWOG S1216 study looking at TAC-700 or Terranel for metastatic hormone sensitive prostate cancer. As many folks probably recall, TAC-700 is similar to abiraterone, although it is an inhibitor more specifically of 1720 lyase, inhibiting androgen synthesis, but without the glucocorticoid requirement that abiraterone has. And so very appealing to people from that standpoint, although a little bit later to the game in terms of drug development than abiraterone, and so kind of competing in that space. In other previous studies, in the CRPC setting, for sure, but now looking at this in the metastatic hormone sensitive setting. So this is a large phase 3 study with over 1,000 patients accrued, accrual happening from 2013 to 2017. Patients were randomized 1-to-1 to LHRH agonist plus TAC-700, which is given twice daily, or LHRH agonist plus bicalutamide. And that was chosen for to sort of set themselves up against the strongest competing agent that they could, even though a lot of folks don't use combined androgen blockade, but just LHRH agonist alone in this setting, at least in this timeline. But I think they wanted to demonstrate superiority over the best performing alternative that they could. Importantly, for efficacy endpoints, overall survival is the sole primary endpoint, and progression-free survival is a key secondary endpoint. Patients included in the study were stratified by disease severity. Although they didn't use the charted definitions, they used minimal and extensive. We certainly have a lot of overlap with high and low volume per charted definition, but not completely. So an isolated rib metastasis actually could put you in the extensive group here. About a quarter of patients underwent prior prostatectomy. Most patients had de novo metastatic disease. So TAC 700 does improve progression-free survival. Significant difference between these curves, good improvement from about 2 years to about 4 years, with a pretty good hazard ratio of 0.58. Again, significant separation between the curves that's maintained over time. However, importantly, this is a secondary endpoint, and for the primary endpoint of overall survival, you do see improvement in median overall survival, but overall the curves are pretty similar. We'll go from 70.2 months to 81.1 months, but the hazard ratio is only 0.86, and that confidence interval includes 1. So this is a negative study, and I think disappointing for all those who were involved, although I think there is additional correlative study that will help us gain some information from that. Moving right along in a very similar space is the PEACE-1 study, although with a different trial design. So this is a 2x2 factorial design looking at standard of care versus the addition of abiraterone or radiotherapy or abiraterone plus radiotherapy. So based on Stampede Arm E and Latitude, abiraterone is widely used for metastatic hormone-sensitive prostate cancer, both high volume and low volume. Based on Stampede Arm H in the HORAD study, post hoc subgroup analysis, and subgroup analysis, although predefined in the Stampede Arm H study, most patients with low volume metastatic disease are undergoing radiotherapy to the prostate, or at least to the prostate, if not more these days. So really trying to find out if both, or if these are contributing independently to improvements in outcomes, or if one can substitute to the other. Also of note, standard of care evolved, especially in Europe where this study took place. So standard of care evolved from 2013 to 2018, which is when this study was accruing. So initially patients received ADT alone. 2015, 2017, docetaxel was permitted as part of standard of care. And then docetaxel was mandated 2017 to 18. This is perhaps a little bit different in Europe than here, where we tend to refer to charted, where there wasn't a clear benefit of docetaxel for those with low volume disease. In fact, it looked like no benefit. Whereas in the Stampede study, the benefit of docetaxel did not appear to depend on whether patients have low volume or high volume. There seems to be consistent benefit. So here, docetaxel is mandatory at the end of this study. Here at the presentation at ASCO, we get a presentation of one of two co-primary endpoints, and that's for radiographic progression-free survival. And we get presentation for the abiraterone data and not for the radiotherapy data. The overall survival and the radiotherapy data will be coming further down the pike at later meetings. So 2x2 factorial design, start off by looking at interaction between the two experimental therapies, interaction between ABI and radiotherapy to the prostate. If there is an interaction, then they evaluate these experimental arms separately. But if there's no interaction, the arms can be pooled for analysis. And in fact, that's what they found, no interaction. And so they pooled the standard of care and the standard of care plus radiotherapy in evaluating for the benefit of abiraterone. They then went on to a hierarchical testing strategy looking at abiraterone and benefit in terms of radiographic progression-free survival in the overall population, and then could go on to the next step of looking at abiraterone specifically in those who received docetaxel. Looking at the baseline characteristics, sorry, let me go back here. Of interest, 57% of patients enrolled in PEACE-1 had high volume disease by standard definitions, and 60% of patients received docetaxel. So pretty close to even split, although more with higher volume, more receiving docetaxel. So abiraterone improves radiographic progression-free survival. This is in the overall population. Again, similar to the SWOG S1216 study, good separation between the curves. That happens pretty early on, continues to separate further out, and that's maintained over time. A little bit wider separation of the curves, improvement in progression-free survival from 2.2 to 4.5 years with a hazard ratio of 0.54. So a positive study for one of the two primary endpoints, overall survival still immature, improving radiographic progression-free survival in the overall population. So then they went on to evaluate it in the docetaxel population. And this is perhaps surprising to me, maybe even better separation of curves, or at least as good as separation of curves, with improvement in progression-free survival from 2.0 years to 4.5 years, and similar but slightly better hazard ratio of 0.5. And so here, this is in patients receiving docetaxel as part of their standard of care, and then also randomized to continue standard of care or the addition of abiraterone, which is given concurrent with the docetaxel then. Importantly, there were no new or worsened toxicities when combining docetaxel and abiraterone with them given concurrently. And so very similar side effects, no worsening of docetaxel-related therapy or toxicities when also giving abiraterone. And this is as opposed to what was seen in Enzamet, where we saw some worse toxicities, including toxicities that we would attribute to docetaxel for those patients who were also receiving enzalutamide. So good safety and an improvement in radiographic progression-free survival. So conclusions for metastatic hormone-sensitive prostate cancer. No role for TAK-700 or Teranol, as far as I know, has been laid to rest for our options for prostate cancer. Trial design is important. So we saw progression-free survival in 2 different studies for the hormone-sensitive space, one with a hazard ratio of 0.58. This was a negative study because progression-free survival is a secondary endpoint, but PEACE-1 is a positive study. Progression-free survival is a co-primary endpoint, slightly better, but overall similar hazard ratio. But because of study design, this is a positive study. One thing learned from the negative S1216 study is that patients with metastatic hormone-sensitive prostate cancer are living longer in this era of patients accrued from 2013 to 2017, with half of patients with extensive disease, whatever, by the trial's definition, and the control arm having overall survival, median overall survival of 70 months. So that's better than what we've seen for other studies in this space. And that may have been contributing to why this was overall a negative study in terms of improving overall survival. Piece 1 shows us that concurrent docetaxel and abiraterone has a good safety profile with very encouraging results. So we have a Cascara study that is currently closed, was open, and we're expecting to open up again. That also is looking at docetaxel and abiraterone for metastatic hormone-sensitive setting, although not given concurrently. It's actually for patients just with high volume disease, and docetaxel and carboplatin are given concurrently with abiraterone maintenance. This study is at a sort of pre-specified interim analysis and is expected to open up in the next month or so. So far, we've actually seen pretty encouraging results with patients tolerating the docetaxel and carboplatin quite well, and actually patients with high volume and generally pretty high risk disease doing quite well, maintained in the metastatic hormone sensitive setting for quite a while with this maintenance abiraterone. And so either concurrent, maybe synergy with concurrent therapy or cytotoxic therapy, and maintenance coming in with therapy that's has a different mechanism of action was maybe a real way to be moving forward in the future. I at least am eagerly awaiting the overall survival from piece 1, as well as the radiotherapy data. I think many of us have not waited on these studies and are quite often using radiotherapy to the prostate in addition to abiraterone for patients with metastatic hormone-sensitive disease that's low volume. And so I think it'll be very interesting to see if this radiotherapy component is still helpful in if patients getting abiraterone either with or without docetaxel. I'm also awaiting the overall survival data of piece 1, and I think that will sort of clinch if this becomes a new standard of care. But I guess my personal opinion is that for patients getting docetaxel, even if the overall survival data is not that impressive, there's not a lot of separation between the curves, there may be considerable value in maintaining patients in a relatively asymptomatic metastatic hormone sensitive setting with therapies that are relatively well tolerated. And so I think this will be a consideration for me if I'm going to be giving patients docetaxel. Should I be considering adding in abiraterone and not thinking of it as an either or? So those are my thoughts on metastatic hormone sensitive, but I'm happy to hear from others or happy to talk about other things at ASCO that may have piqued your interest.
I think
David, that was great. Go ahead, Ashley.
No, please go ahead.
I was going to say that was a great presentation as always. Lots of interesting things. I was going to just tell the audience that we're going to do a kind of just update, almost activation meeting in 2 weeks regarding the PYL PSMA compound, and I didn't want to steal any of David's thunder, so we reserved that for later, and we're going to have some representatives from the company just work through the kind of work process that will be required for us to get the test, and we'll go over timelines for that test. And I think that certainly is a step in the right direction, or a step in a positive direction in terms of enhanced staging for our patients at this point in time.
Yeah, thanks, Ted. And I think it'll be, so hopefully soon, and we'll hear more about it at that discussion, we will have this imaging available. The FDA approval is really more for staging around the time of prostatectomy or in the biochemical recurrence setting. But the gallium-68 scans that were done in the VISION study and thinking about who's a good candidate for PSMA-based therapies. Those are more difficult to come by, and so I think we still have to figure out in the field, or maybe this will be dependent on the FDA and what this approval looks like, if those F18 PSMA PET scans would be an option for thinking about the radioligand therapy, or if that would be available once we can do them, if they're going to be utilized at later disease states as well.
Yeah, that's a good point. You know, the FDA's approval for the PYL compound is a little bit more, it's a little broader, it's less specific. So they were a little bit more articulate with the G68 compound talking about biochemical recurrence. But you know, in early discussions that we've had for NCCN, the PYL compound, the F18 compound, it really just says recurrent prostate cancer. So, which opens a lot of doors.
Yeah.
And so, you know, how the insurance companies will interpret that and pay is to be determined, but certainly, you know, that could be quite interesting and lead to opportunities. But of course, as you mentioned, how the scans perform will be something that needs to be studied in a, you know, in a systematic registry or prospective fashion, I think.
Yeah.
David, for the Piece 1 study, do you know, did they separate out for the progression-free survival? Did they separate out a radiographic progression-free survival from a PSA progression-free survival? Do you know if they pulled that out of there just to see if there's an early indicator?
What was presented at ASCO is radiographic progression-free survival.
Okay.
Yeah, it's whereas for the SWOG study, that was just progression-free survival, not merely, so which included clinical or biochemical, I think, so
Right.
PSA progression. But for Piece 1, that was radiographic progression-free survival. I'm assuming they also have PSA progression. I actually don't know the protocol details. In the presentation, there was a discussion that it looked to me that the timing of imaging was a bit loose, perhaps, in that patients, I think what I saw is that imaging had to be done at least every 6 months once the PSA started to go up. I do have patients with high volume disease that have very good PSA suppression, but I'm imaging even in the absence of PSA progression because I do occasionally, not most of the time, but I do occasionally see radiographic progression even in the absence of PSA progression. And so I don't know all the details of that protocol and if they were missing these events and really waiting to image until there was PSA progression. I'm not sure about the details about that.
So, but for now, basically, it sounds like you're not going to really change your practice, except, you know, maybe enroll onto the open trial, the Cascara, obviously, and then maybe in selective high volume patients that don't want to do a trial, you might add on Abby with your Taxotere, or are you just waiting?
Yeah, that's a good question, and one that I haven't totally settled in my mind, and I'm happy to hear from others. Of course, we are always trying to have patients participate in clinical trials, and so for most patients that are docetaxel candidates or ones with high volume disease that I would be tempted or encourage patients to consider docetaxel. Most of those patients I would be discussing the Cascara study with them, which is docetaxel plus carba, and then maintenance Abby. We are also working hard to open soon the PSM addition study, which is AR pathway inhibitor with or without the lutetium 177, PSMA 617 therapy. So For those getting AR targeted therapy, that would be the clinical trial that they'd be eligible for. So, but for people not on study, just getting standard of care, I think I will probably be moving more towards doing abiraterone in addition to docetaxel. So the ARCHES study was enzalutamide study, where you could have had docetaxel that was completed prior to starting enzalutamide, and there too you saw a progression-free survival benefit that did not diminish if patients got docetaxel. I think there is something to be said for, you know, even if there isn't a large overall survival benefit, I do think that there is a benefit to being maintained in the metastatic hormone-sensitive space. And so I think there's a strong argument to be made to pursuing that strategy, even in the absence of having the overall survival data. And, you know, the trial design had co-primary endpoints, and it's a positive study based on the progression-free survival. So, you know, it's new data. I'm still sort of thinking about it and happy to hear from others, but I think I'm leaning more towards adding in Abby.
Great. Well, that was fantastic, and it sounds like there's, I mean, honestly, in all the spaces, it sounds like there's like a lot of biomarker and secondary analysis to be done in the VISION trial for sure, like you mentioned. And I think a lot of these hormone-sensitive combination trials are also they're also trying to do a lot of biomarker correlates beyond just high-low volume, and that's going to be very fascinating. That was excellent. Does anyone from the audience, anyone else have any questions before we wrap up? We have like a minute or two left. Okay, well, great. David, thanks again. I know you just talked with us about a month or two about AKT-P10 pathway, and that was phenomenal. And this was a very thoughtful review. So thank you very much, and thanks everyone for staying through the evening.